Greetings and salutations. This is Abdelhadi with The Bitter Truth, where we may not have all the answers, but we're going to ask an awful lot of questions. You can also become a bitter pill or whatever on the Patreon link, Patreon.com/The Bitter Truth, or you can visit us at thebittertruth.info. Appreciate support of the show. You can always listen to us for free on iTunes, YouTube, Spotify, you name it, we're there. So today, I'm very excited. Guest that is going to enlighten us on a lot of things concerning the Medicare for All issues in this country. She has an extensive background in the Medicare provider realm, in addition to the hospice arenas. She's also a member of the Red Berets. Lisa Theobald, how are you?
I'm great, Abe. How are you doing?
Hey, just getting my second shot next week. I'm excited about that, and hopefully, start moving forward with the rest of civilization, that kind of thing.
Yeah, I'm up for my next shot next week too. It's a kind of a nice sigh of relief, isn't it?
Yeah, I mean, the first one I slept for 15 hours, and so at least I didn't get the flu. But yeah, and then I'll get the next one next week, and hopefully, everyone starts. I've been pretty impressed with the way they've been getting it out. To be honest with you, it's like I get where I went. We must have had like 1,000 cars. At the
oh wow
at the Formula One racetrack, and they had like 30 lines, and I was in and out in like not even 35 minutes.
That's terrific.
Yeah, it was pretty.
Yeah,
we
went to a gymnasium.
Yeah.
We went to a gymnasium, and there was at least 500 cars there, and same thing, in and out.
Yeah, real quick. Hey, so talk to me. I was under the impression that Washington State was moving forward a little faster with Medicare for All in their state, but apparently not, right?
Well, they don't have it yet. What happened was whole Washington is the entity that has been working extensively for years on the legislation for single-payer healthcare in Washington State, which, by the way, the current legislation is under review by the economist, Mr. Friedman. He did the review of the last bill that is actually going to save the state $9 billion a year, and maybe more, because they redid the bill this time around. A couple of years later, we've been working with one-payer states. Georgia Davenport, not me, but Georgia Davenport has been really involved with this, with the board. And we're flushing out pitfalls around single payer because, nobody's actually done single payer lately. There is a state, and I'm sorry, I can't remember what it is, that does have a form of single payer.
Right.
But it's not exactly what we're trying to do in Washington State, right?
Mm-hmm.
But the good news is all the states that are working on this legislation are working together. So
right.
They're not doing it in a vacuum anymore. And that's really helped flush out some of the things that could go wrong with it. And we've got waivers for certain things so that all the money can go into a trust. It would be the Washington Health Trust. And then that's what your premiums would be paid out of, just like the Medicare trust that pays out of the Medicare taxation that you give through your employer.
Right.
That's where your Medicare funds go. So it would be the same for Washington State. It's pretty incredible legislation. You can go to wholewashington.org and you can find out about the legislation, and you can find out about the organization and all the things that they've been doing. Pretty simple. The legislation is out there, and they're working on putting together a ballot initiative. They got the initiative approved. The board voted, and they are taking it to the people because they were about to introduce the legislation to the legislature of Washington State. And lo and behold, somebody in the legislature introduced a bill, 4-page long bill, that said that they're going to wait 3 years and do a study, which is ridiculous.
Yeah.
They've been working on the legislation for 4 plus years. And so the board just said, okay, we're going to take it to the legislature through a ballot initiative, which means that if we need 350,000 signatures And you have to pad that because you're going to get people that sign that aren't registered voters or aren't from the state. That's inevitable. So the goal here is to get 400,000 signatures to make sure we have enough. And if we do that, the people in Washington state will be able to vote on whether or not they want single payer health care. Okay. And so right now, the board is in full gear, full on recruiting people who will help with signature gathering, finding partners within the community and educating. They're formulating the education to give to the community so that people will start talking about it and know what this means and how it would work. And, all the questions that come up around it, right?
Sure.
And they're really thorough. They've got fabulous people on that board. Lots of them are nurses. They've got, obviously you need to have a lawyer to put legislation together. She's fantastic. And then we have the Red Berets, Laura Fielding, who is the founder of the Red Berets. She's the gal that knits Red Berets. If you're out on Twitter, you might have seen her. It's hard to miss her. She's pretty relentless. And we are a totally unaffiliated with anything group of crafters who got behind Laura's idea of knitting Red Berets as the symbol for Medicare for All. We've always been behind candidates, local and Bernie's campaign, to do any way we can get this, either a national level piece of legislation that gets passed, which would be optimal, right? It would be better to do this all at once with a bill that, we all believe in. But the hard truth of the matter is that Joe Biden has vowed that even if it were to come out of the Senate and the House,
I know,
he was going to veto it, right?
Right. So
one of the things that we come up against, and I have to be really honest with you, I've been working on this for probably 6 years all up, and I've come through the evolution of thinking that state single payer was not the way to go. I was suspicious of it. Why would you try and do this one state at a time? That seems ridiculous. The truth of the matter is that Canada did it this way. Saskatchewan passed.
Okay. I didn't know that. Yeah.
Yep. Saskatchewan passed single payer, and it was a total success. I mean, everything has its pitfalls, but you learn as you go.
Sure, absolutely.
And then they passed it province by province, right? So now they've got a single payer system in Canada.
Okay.
It's once we get one state to go and people start to believe that we can do this, it adds pressure to the national effort for Medicare for All. And it's a proving ground for, does this actually work, right?
Sure.
And what doesn't work, we'll learn from.
Right.
So we're the Red Berets. We're a bunch of crafters. If anybody likes to knit and crochet, we have such a demand right now for our berets. And we really need, people who craft. They love to sit down and knit. These things take a couple of hours to, 6 or 7 hours, depending on your skill level and how detailed you want to get. But we sure could use some more knitters. And we would really love to do a 50 state strategy where we had knitters who were making berets, and it's a donation of time. But if you believe in single payer healthcare, the people that believe in this, they're just going gangbusters.
Well, let me ask you a question too. I mean, because I've been surprised the last few years of business owners that I've run into that I'm actually close enough to have this conversation with. And I mean, I've met like really conservative guys, who mathematically they're like, dude, it's, like the number one cost of a small business, if it's 100 to 200 people working there, I mean, that guy's shelling out like $1 million, $2.5 million a year for health insurance. Right. And then the contribution by the employee is in the high low 5-figure range. Like you're paying, these guys are paying $9, $10, $12,000 a year out of their paycheck. You got a guy who's maybe making 60 grand a year with a family of 4. He's paying about $900 a month and that's just his contribution. It doesn't matter, or not doesn't matter, but it like doesn't count that the denials he's going to get, what the insurance denies his payments to be. So on top of his copays, his contribution, and then what the insurance denies, that ends up being, and I've had a few conversations with small business owners that own 150, 100-man groups. And they'll say, yeah, man, my Medicare contribution is like $150,000. I'm paying $1.5 million for insurance. He's all, and he goes, that would add to my bottom line, and I can give the guy a raise without me paying for it, because now the guy gets a $12,000 a year raise, and he's not taking that out of his paycheck, except for his little $100 a month, $150 a month contribution, which is a fraction of what he's paying now.
Bingo. You've touched on so much. And let me just segue.
Yeah, unpack it. Yeah.
First of all, I'd like to just speak briefly about my background and why I know what I know about healthcare. I was a director of finance for 10 years in hospice and home health operations, both a nonprofit and then 6 years in a for-profit hospice and home health operation. When I started working in hospice, the ACA was not introduced yet.
Right.
And then it was, and my next 7 years, I had to implement it. And when you're a CFO of an organization in healthcare, it's not just how much is this going to cost me. In healthcare, everything that you do for a patient is captured in something called an electronic medical record, right? It's a system. And everything that you do for that patient has regulations and standards and quotas around it. And that goes on a claim. Okay. So when I say that I have seen it all, just because I only did home health and hospice, part of being a Medicare provider is finding out why your patient is coming on service. And the only way to do that is to reach out to the referral source, be it their physician, if they're coming out of a hospital and need to come on to home health, or they have to come on to hospice, I've got to get their medical records out of the hospitals. Or if they're coming out of a SNF and coming home, I have to go to the SNF is a skilled nursing facility. We would have to go to the skilled nursing facility and get all those records. What I'm trying to say is, when you're a healthcare provider in this environment, in order to do it as a Medicare provider, which gives you the license to bill for those claims, and any other insurance payer, because all of the credentialed insurances have to follow Medicare guidelines. All right. So in long and the short of it, all the documentation has to be the same, pretty much. Okay. So I've seen firsthand, and remember now, I did hospice and home health, but the bulk of it was hospice. I've had to bill those claims as a provider, which means if your provider of healthcare is providing services for you as a patient, the provider bills that claim. Okay. If they're successful and know how to do it, we'll talk about the number of errors in claims that get billed later. But let's just pretend for a minute that everybody knows how to bill every single insurance plan and every insurance carrier that they're credentialed with. Oftentimes, something will get kicked back, and it'll take a month before we even figure out why they denied that claim. Okay.
Right.
If your medical provider doesn't have a robust, educated billing department, what happens when they deny that claim? The provider will say, well, we don't have time for this, bill the patient. Okay. That's how lots of people end up with huge medical bills that come in the mail.
Mm-hmm.
And nowhere on there does it say that there is a very distinct possibility that this is a processing error. or a billing error.
Right.
And that's why this claim was denied. Okay. Lots of people don't have the wherewithal, the patience. They don't know what their rights are. And they just start paying those things. Right. My team never did that. We worked our insurance claims to payment. And we never passed along any of that to the family, okay, or the patient. We, for the rarity, all right?
Sure.
Now, my state's a little different than a lot of states. You can't go after a family for a loved one's medical bills here in this state, but lots of states aren't like that, okay? So people are getting medical bills not understanding that there's a darn good chance that it's a billing error.
Sure.
Right?
Sure.
And they don't know that. And they pay them, or they think, oh my God, I'm going to lose my house. Right.
Right.
So that happens a lot. Okay. When the ACA was first enacted, when they first voted on it and it came out as a director of finance, of course, I'm curious about what's in that legislation, right? We remember now when the night before they voted on that bill, and they did it late, so hardly anybody was watching. We all went to bed thinking we were going to get a public auction. Okay.
Right.
Everybody thought that was the last news on the news. If you watch C-SPAN, which I have to say I'm guilty of, by the time I shut the TV off, I would say, okay, I'll wake up tomorrow and see what this public auction looks like.
Right.
And that bill came out the following morning. It landed in my inbox. I went and printed all 2,000 plus pages out, plunked it on my desk, started punching holes in it to put it in a binder. And I sat down to read the executive summary. I read like 4 of 6 of the pages, and I walked into my boss's office and I said, Jim, they gave the mouse the cheese. And he said, what in the world are you talking about? And I said, the Affordable Care Act, they handed everything to the insurance companies.
Yep.
And he looked at me and he's like, okay, calm down. And I said, Jim, I can't calm down. I said, do you realize what they've just done? There's no negotiating power for pricing. There's no negotiating power for pharmaceuticals. They can vertically integrate. It's a 7-year phase in. But what I'm seeing here is going to turn everything upside down.
Right.
And I didn't even read the bill. I read the summary, right? I remember my boss saying, Lisa, the sky's not falling yet. They'll fix it. Yeah. Well, they never fixed it.
Sure.
Okay?
Of course not.
So let's talk about your small business provider that you referred to earlier, who was telling you that, hey, this would be great. It would save money on my bottom line, right? And you said to me that they were paying $400 to $500 a month for their insurance. Okay?
Some, I mean, and that's on the low end. I know families of 4 or 5 paying upwards of $900, $1,100 a month. Right.
Now, let me tell you why that is. First of all, and things have changed as companies have had to adapt to the sheer cost of healthcare. All right.
Mm-hmm.
It used to be most of them covered 75% of your premium and you were responsible for 25%. That was pretty standard.
Right.
And you would end up with an 80-20 copay until you hit your deductible and, right?
Mm-hmm.
Some plans are better than others.
Sure.
You have more choice with your doctors. Some plans are very restrictive. They're what they call an HMO.
Right.
Which is, you've got a small group of doctors that you can go to, and that's it, right? Well, one of the really big things about insurance, and this is why the industries themselves, the small businesses and even the big businesses, should really be scrutinizing this, okay? But not all businesses, because remember now, we've vertically integrated healthcare. And that I'll touch on that in a little bit and let people understand what that means. However, because I was in finance for so long, and I worked for a bank and, in the controller's division and all of that. I know how all of this goes. If you're an industry, say a healthcare provider, like I worked for, okay, underwriting for insurance plans is very, very complex. One of the things that people have absolutely no idea about is certain industries, certain professions, operations, okay?
Right.
They're categorized in risk factors.
Okay.
Now, I'm just going to give you one example, and I think it's the clearest example that kind of gives everybody an idea. If you are a healthcare worker, nurses, if you've got a field operation of nurses that are going home to home every day for hospice or going home to home every day for home health care, okay? And you have doctors too, but basically it's run out there by the nurses. Your doctors are behind the scenes reviewing notes and prescribing for that operation. But your nurses and a lot of healthcare professionals, we are one of the highest risk operations industries to insure as employees. Now, ask yourself why that might be. A healthcare provider, 9 times out of 10, is the worst patient ever.
Right.
Okay?
Yeah.
And they know this. All right? They know it. Guys that work in heavy construction, expensive to insure, right? Because you have a chance of injury.
Sure.
Okay.
Sure.
And that goes to your labor and industry. But we all know that people get hurt and they don't always file an L&I, labor and industry claim, workman's compensation claim.
Sure.
If you live in my state, people are terrified of doing that because they're afraid they're going to lose their jobs, right? So those populations, they have a different underwriting than, say, if you're an accountant, you're an accounting firm, right? And most of the people that are working in your accounting firm, except for the partners, are younger, right? Out of college, hungry to make a living. They're not if you audit, you're traveling around, but you're not working on heavy machinery.
Right.
You're not a healthcare provider, right? That's exposed to all kinds of stuff and lousy patients, right? Last ones to go to the doctor when something's wrong, that kind of stuff.
Right.
So they're cheaper in the grand scheme of things to insure than a healthcare provider.
Sure.
People don't know about this, right? So you go to work, you get a job, you're like, finally got a job, and they're going to give me benefits, right? And the last job that you had might have been in an industry, even if you're a support staff. This is the hard part about this. You might have a lot of nurses, but everybody in the back office that's relatively healthy, maybe they're all young, they still have to pay the premium for the healthcare industry as an operation, right? So if you're high risk, it might cost $1,100 a month for someone to get insured, okay? As opposed to your last job where you didn't work in a high risk industry and you only paid $450 a month for your coverage.
Right.
That's why people are so shocked and in disbelief as to how this works. They hear that some people are paying $1,200, $1,300 a month for their health insurance. And, you hear people quip back, well, you need to shop around. Those are people who truly don't understand.
Well, and they also, they don't understand the other fundamental too. I mean, I'm in Texas, and I know that the primary employee, will get a reduced rate on
or sometimes nothing.
Right.
They don't have to pay anything, right?
But then
the
family members are now being sold insurance at a quote discounted rate, and that's where the $800, $900, $1,100 comes in. Yeah, because the guy or the lady works there, she's paying $175 a month, but now for each kid and her spouse or his spouse, it's going to be $300 or $400 each of those people.
Right.
And then it adds up. You got a family of 5. Now you're looking at like $1,200, $1,300. Now if you make like 60, 80 grand a year, that's a full, 25%, 20% of your income. And so for the employer to say, hey, I can give that guy a raise, I can give that woman a raise, And then my bottom line is boosted because I'm no longer paying this. I'm just paying Medicare. And my Medicare contribution is like not even a fraction. That's where when people say shop around, I mean, and people that say stuff like that, I have found have never been through things like that. I've got several friends
have no idea.
Yeah. If you've been through a denial process where, you're looking at six figures, like a $300,000 nut for stuff that was approved before. And now all of a sudden they're saying, hey, oopsie daisy, we miscoded that. So now the whole operation is done. And you owe us because Blue Cross, took the money back from the hospital. So now you owe us. And at best, they might get on a $300 a month payment plan, which that will never get paid, or they just declare bankruptcy, right? Because and that's why we get 1 million bankruptcies a year for medical. And these people had insurance. That this isn't criminal just shows, the failure of the privatization of everything.
It's, it was bad 5 years ago.
Yeah.
Now, I'm just going to be really raw here.
Oh, please. Yeah, it's called the bitter truth, not the big wet kiss. So do your thing.
It's not sustainable.
Mm-hmm.
It wasn't sustainable 5 years ago.
Right.
Now we're in a pandemic. You know what's happening? You want to know why all these insurance companies are making money hand over fist? Nobody is going to the doctor. And everybody's got to think about this now. If you're prepaying for your cell phone and your cell phone falls in the toilet and you still pay your bill, your phone's not working, right? And let's just say for a second that for whatever reason, they're not going to give you another phone because you're under contract and they just won't give you one. I know that's absurd, but it's kind of the same concept.
Sure.
Okay. And you prepay your medical insurance. You pay they take the deductions out of your paycheck for the upcoming 2 weeks, usually, unless you're on a monthly, when some people get paid monthly, they're paying for the upcoming month of insurance premiums, right? So you're always out of pocket your next month's premiums, okay? When people aren't going in to the hospital to have what they will deem elective surgery, okay? Elective surgery can be that you can't walk because your knees need replaced, but that's not going to kill you. So that's going to be deemed elective at this point in time.
Wow.
Right, okay.
Wow.
Yes. I've had a mother-in-law sit in a wheelchair for 9 months waiting to get her hip replaced. Couldn't move, couldn't transfer from her wheelchair to her bed to the bathroom, right? But it was elective surgery because she was home, she was stable, and it wasn't going to kill her. She got zero quality of life.
Sure.
Right? This happens.
I know. I mean, we've had over 500,000 COVID deaths, and a third of those people had no insurance.
Right.
And I got a good friend of mine here in town. One of the guys he works with got COVID last year, and he's still looking at $106,000 of denied claims. It just goes on and on. And so, and then I want to touch on to some of what because we got a few minutes here left on the show, and I'd love to have you come on for a part 2 because I got a bunch of other questions I was going to ask you. So you kind of had the come to Jesus moment where we probably aren't going to get it nationally. Biden ran on at least a public option not
this time around, not this ad.
Last summer he was saying it, but now there's no peep. It's over. I mean, if anybody thinks he's going to do it, they're smoking crack. So do you honestly now think that the state by state option is a better way to go?
Let me tell you something. We get one state to enact it.
Mm-hmm.
The flood of people that are going to try and move to that state, you watch.
Oh, 100%.
Right? Not only that, but let's just say for a moment that it works. Okay.
Mm-hmm.
Now, everything has its pitfalls initially, right? You get, 300,000 people in a state that had never had healthcare before, all of a sudden have healthcare. You've got to find providers and get them to that need, right? There's demand.
Sure.
You've got to get that demand met. Okay. So it's going to be rocky. Okay.
Right.
But it's going to be rocky because we need to put the distribution of healthcare down on the ground. Okay.
Right.
You're going to recruit doctors.
That's right.
You're going to put up facilities. And let me talk to you about facilities, right? Like home health care shops, hospice shops, right? That's not real hard. You get a bunch of nurses. Hospice, if you have a demand, okay? Hospice and home health, you send the practitioners there. All right. You train them up. That's behind the scenes. That's not hard to do. Hospitals are a little different, right? But what we've got right now in this country is crisis care.
Right.
We've got to get back to preventative care, which is what we had in the late 80s, early 90s, right?
Up until that. Well, now big pharma, they don't want that.
Exactly.
They want to sell you a pill.
Can't make as much money, right?
Right.
So, let's just say it works in one state, and that it's not speculative. The pro forma that was done, that it's going to save the state of Washington $9 billion annually.
Wow.
One state, 7 million people in that state, $9 billion in savings annually. Can you imagine what they can do with that money?
Yeah, like schools and and infrastructure.
Build the hospitals, right?
That's right.
Build the hospitals.
Yeah.
Get the doctors trained. I don't know. Do a public works. $9 billion.
That's a lot of money.
It's a hell of a lot. Hey, let's clean up Hanford for God's sake, because that's part of the reason why people are so damn sick. It's a nuclear waste dump.
Right.
It's that kind of stuff, right?
Right.
Small business owners, in all honesty, have a hard time talking about this, because one of the other things that people don't realize is that corporations, you never know where the insurance allies are. And when I say that, corporations will partner up with the insurance industry, and they will do an initiative that, is going to be profitable down the road. And they do this because insurance companies, they're like banks without a capital constraint. You know what I'm saying? Like a bank has to harbor so much of the assets on their balance sheet so that they can be solvent if there's a walk on the bank, right? Or if their loans go bad, they've got to have cash reserves to take care of any potential contingency, barring a catastrophe, right? Insurance companies don't have to do that.
Yeah,
they don't have to do that. There's no capital constraints there.
Right.
And they're sitting on mountains of cash.
That's right.
Sitting on it.
Sure. And on top of bailouts that they get, because we continually bail them out every time there's someone.
Right? $40,000 for 1.3 million people for 9 months, I think, or 6 months. I'm not sure. Okay. That's what the COBRA relief did in the stimulus.
And that money could have gone to Medicare for all. The amount of money it went for that COBRA stimulus nonsense, for us to give insurance more money. I mean, COBRA is
for
ridiculous.
9 months.
Yeah,
for 9 months.
Yeah, for 9 months. And COBRA is ridiculously priced. COBRA is the biggest scam running. It is the biggest scam running. And
it is.
And so to pump money into that and to have Pelosi with a straight face say, "Oh yeah, that look at the relief we're doing for COBRA for people that lost their jobs, and then 9 months out, like say you don't have a job, now you're responsible for your COBRA bill."
Yeah, exactly.
That's not a permanent fix.
No, it's not. It's garbage.
Yeah,
it's garbage.
That's right.
Because you know what happens with COBRA, and I don't even know now because I haven't done this in a couple of years, but it used to be that you had 3 months. You get fired from your job. You've got 90 days to retroactively pick up COBRA. Okay.
Right. That's right.
Right. So a lot of that money is going to the 3 months ago when I got severed or lost my job or whatever, right?
Right.
Here you go. Here's the 3 months that I didn't even ask for COBRA, but you have to pay it in arrears.
Right.
Okay. So this is like, it's heinous. It's criminal what's
It's
going
criminal.
on.
Well, I want to wrap this up and move on to, we carry on this conversation another time, but what's so criminal?
I'm sorry. I wanted to answer your question.
I say your thing. Okay.
Do I think that this is the way to go?
Yeah.
Absolutely.
Good.
Because if you and I find out that Washington State did it and they've got $9 billion that they can do X, Y, and Z with, and everybody's covered, and they're building hospitals and they're putting in clinics to take care of people, and they're hiring medical professionals that don't have to deal with insurance denials and all that crap. Right? You think you might want to go work in Seattle?
Right.
Think about it. And you're going to get unions, everything.
And that's the thing too, is, in the last couple of minutes here, I'll make this point and we'll pick it up. I'm going to just make a note to myself here. But like last summer, I got on a health share program, if you're familiar with those things.
Yes, I am.
Way cheaper than ACA. There's issues with it, right? It's not perfect, because a lot of it's reimbursement.
Nothing is.
Right. And this is not like, even though they run on the reference-based pricing model, they don't own their network. They don't rent a network. So you have to find a provider. So once you find the provider and they go, yeah, we take it. Cool. When I was calling around, just Texas, just Austin, myself, I must have made about 15 calls to different clinics to see if they took it. And they all said the same thing. She goes, oh, we don't take regular patients anymore. We're only taking Medicare.
Yeah.
And the 10th or 11th clinic I called, I said, well, why is that? She goes, because they pay us.
Not only do they pay them, but it only costs them 3% to process the damn claims.
Not 28%, which is the industry average.
Exactly.
Right.
Exactly.
And so I was kind of surprised by that, because usually, all I hear about is, oh yeah, well, Medicare, they pay lower. And my brother,
no, they don't.
And I got a brother who's an MD, and he deals with this crap all the time. And he said a few years back, we're talking about this, and he put it the best way. He said, look, Medicare might not be the sexiest money, but they pay. And I don't get a reception letter like I get from Aetna or Blue Cross, where they tell me to go after Joe Smith. Now I'm a bill collector, and I got to go get 85 grand for Joe Smith, because the surgery that they approved to put the stent into his heart, they now said, oh, oopsie daisy, that part was miscoded. So now, instead of just not covering the part, they're not covering the whole surgery. Right. And
you know what?
It's a scam.
That's not even what they're doing. What they're doing when they do that, it's not that they miscoded it. I lost that.
That's a little blanket term for them, just.
Oh, I know what I was going to tell you. Yeah. They'll do audits.
Right.
I actually had a payer that pulled every claim I had billed in the prior year, and they electronically come into your bank account as a payer, as a provider, and take the money out. And then they tell you why.
Right. That's what happens.
My prior year's revenue stream off of this plan that I billed, that I was credentialed with, just one day, I got 50 letters in the mail and another 50 like the next week. And it just kept coming. They pulled all my revenue from the prior year. And we had to do what they call a appeal to get it back.
Oh my God. Okay.
Yeah. And that's what they're doing to the medical providers.
Oh,
I know. Why do you think you never get enough time with your damn doctor? Right. And every time you change an insurance plan, you've got to change doctors. So, nobody's got your medical history. That's by design. Start all over. Absolutely. Well, listen, Lisa, let me do this. We're definitely going to pick up this conversation. Folks, my guest has been Lisa Theobald, and again, thebittertruth.info. Visit the site. We got some fabulous swag to make your life better. Appreciate the support. If you want to get a t-shirt, or just subscribe to patreon.com/thebittertruth, which that link is also at thebittertruth.info. You can always hear these shows on iTunes and Spotify and Podcast Addict and everything else. So if this stuff makes you uncomfortable, it's supposed to. Sleep tight.